Thank you so much for this wonderful opportunity. And I work as a metabolic medicine physician, and it's very important to say when I look at these patients like here with increased visceral adiposity who may have a sedentary lifestyle, the purpose of my treating them is not to make them lose weight, but in fact to turn them like those patients in the background that have a better quality of life. So I do run an obesity clinic, but it's not a weight loss clinic. I don't run a slimming club. What I'm doing is trying to increase the health of our patients. But therefore, we are really at the start of a revolution, and it's a wonderful message of hope that I think we'll be able to go through in the next couple of minutes. These are my conflicts of interest, and we work with lots of different companies, with pharmaceutical companies, with nutrition companies, exercise, as well as surgical companies, because we don't think that obesity is one disease. And therefore, it's incredibly unlikely that we're going to find one silver bullet. But as is shown by our next character, this is Sisyphus, our Greek character that's been thrown into the depths of Hades. And you'll remember that what he had to do was roll this rock up this hill every day. And every day he got to the top of the hill, what would happen is the rock would roll down. Okay? And you would have to start over again. Now, all of us in this audience, certainly me included, have made this mistake. At some point in our lives, we have told our patients what you need to do is eat less and move more. And every time you've done that, you've asked them to roll up this rock. And they can do that for a period of time, but they can't sustain it. So I would suggest that we need to stop doing that, because that certainly can cause harm. That's not the same as saying that we don't need nutritional therapies, exercise therapies, because those are treatments for the disease of obesity, in my instance, or for cardiovascular risk prevention. But asking somebody to eat less and move more is like asking somebody with clinical depression to cheer up. It's just not what good medicine, is about. So what we really are talking today about is how can we use how the gut talks to the brain to actually get better understanding of the disease, but ultimately also better treatments. And when you actually have a meal tonight, or even this lovely lunch that you've just had, is what you've done is you've stimulated physiological processes. For example, the hormone ghrelin from your stomach is now lower because you've eaten. The gut hormones such as PYY, GLP-1, and oxyntomodulin are higher because you've just had a meal. Your leptin levels are pretty stable because you haven't starved yourself, you haven't lost any weight, and therefore all of these signals, including the vagus, goes to the central areas, and it's really this understanding that's changing our view. Because if you ask most good medical students, tell me what organ is responsible for the disease of obesity, they will flounder. Right? As many of us in the audience, because it's not adipocytes that causes the disease of obesity. Abnormal and pathogenic, or pathological adipocytes is part of the disease, but it's not the cause of the disease. What we are understanding is that at least 80% of obesity is driven by the central areas in the brain, the hypothalamus, the area postrema, the nucleus tractus solitarius. And therefore, now we are thinking about obesity as a neurological disease. And that's why it's hard for me and for our patients, when we treat this, but at least this understanding is helpful. But what do we have, to actually combat that? And we have all these gut hormones, and this is when they've been discovered. And what we're going to focus on is only a small number of them. So thinking of the gut as one of the biggest endocrine organs in the body helps you understand the power that we have when we actually are using this. Now, of course, we've learned tremendously from bariatric surgery. And here I'm showing you a gastric bypass and a sleeve gastrectomy. And at least I need you to understand that the way these operations fundamentally work is by taking food from the mouth through the esophagus and putting it into the small bowel very rapidly. And with the sleeve gastrectomy, what you have is food enters the mouth, enters the esophagus, enters into the sleeve of the stomach, and this is a high-pressure system that forces food into the small bowel. So what these operations do is they increase the signal from the gut to the brain by just putting food into the signaling system, the small intestine, and therefore harvesting what the body has given us to do. One of the ways that these operations work is by increasing gut hormones. They also change bile acids, they also change microbiota, and they have multiple effects. But one of the ways they change is gut hormones. And GLP-1, as illustrated over here, is a 37 amino acid peptide. So what Novo Nordisk has done with liraglutide is they change one amino acid, so it still has 97% homology, but now a half-life of 13.5 hours. Or they've changed two amino acids in semaglutide, 94% homology, and a week of half-life. And all this is now doing is exactly what bariatric surgery will do to some extent, is it allows these peptides to bind natural receptors that we are all interested in, whether or not you're interested in the GLP-1 receptors on the SA node in the heart, or you're interested in the GLP-1 receptors in the kidney. Now we actually understand this is just physiology. What you're doing is just increasing signaling at the receptor system. But approximately 7 years ago, there was like 13 randomized controlled trials, all showing that bariatric surgery is superior to best medical care when it comes to glycemia. But we wanted to go to the next level because, as you pointed out, I don't really care what my patient's sugars are, when they have diabetes. I think of diabetes as a systems disease. I'm interested in reducing micro and macrovascular complications. So it's really the complications of diabetes that drives the morbidity and mortality. So what we wanted to do is investigate whether or not we can use surgical treatments or medical treatments in those patients with established microvascular disease. So we took patients with type 2 diabetes, with urine ACRs above 30, with BMIs between 30 and 35, and early stages of kidney disease. And this has just been published a week or so ago, the 5-year outcome. And what we did is the best we could do at the time. So we combined the best medical treatments that we had together with surgery plus best medicine. So that was already a leap of faith, where we said it's not surgery against medicine, it's surgery with medicine. So we allowed our patients to remain on ACE inhibitors, statins, metformin, and multivitamins after they've had surgery. Really, our purpose was to boost surgery as much as we could, okay? Because at the time, the evidence showed that surgery was going to be at least 5-fold better than the best medicine that we had. So our power calculations were very safe. We were really, we knew sort of what the answer was, even before we started, because the evidence was so overwhelming, showing you that surgery is happening. However, as you know from your own practice, about 7-8 years ago, we really understood the value of GLP-1s and SGLT2s. And actually, without very little evidence, even the big societies, the ADA, the EASD, endorsed this idea that we can combine, GLP-1 receptor analogs and SGLT2s. And that's what we did. So we said, look, we have to do the best we can, because ultimately we don't want to be criticized that we didn't do a good enough job on the medicine side. Little did we know just how good it will be when you combine SGLT2s and GLP-1s and you really drive diabetes disease. And this is the primary outcome at 5 years. So we defined whether or not somebody is in remission or not in remission for their diabetic kidney disease based on their urine albumin creatinine ratio. And you could see that at 1 year, 2 years, and 5 years, all of these patients started with diabetic kidney disease. And you could see that 60% of our patients in the best medical treatment were in remission when you look at just urine albumin creatinine ratio. Compare and contrast that with 70% of the patients that had surgery plus medicine. So that's a great thing about being an academic. You only learn when you are wrong, and I'm wrong most of the time. And that is really valuable, because what we have now seen is just how powerful our medical treatments have become. This does not undermine the value that surgery has, because when we look at it as a continuous variable over here, you can see that surgery outperformed best medical treatments when it comes to urine ACR as a continuous variable. But also, just look at this effect size that we were able to achieve when we combined GLP-1s plus SGLT2s. When we looked at defining early stage chronic kidney disease remission, so remember most of our patients were effectively stage 2, so most of them had normal GFRs or above 60, but with raised albumin-creatinine ratios. But what we were now able to see is which patients had both a GFR above 60 and had an albumin-creatinine ratio below the threshold. And we can see with best medicine that was 52% versus 63% with our combination therapy. So when it comes to weight loss, there's no doubt that surgery outperforms best medicine. But you also need to see that there are responders and non-responders even when we deliver surgery. So there's patients over here that had a good gastric bypass and didn't lose much weight. And you had patients over here that with a combination of SGLT2 and GLP-1s almost lost 20% of their weight. Now the drugs that we had available at the time was EMPA and liraglutide, so those were not the third generation GLP-1s that we are talking about now. So we saw that 22% of patients with the best medical treatment achieved more than 15% weight loss, and that's really where we think we're starting to make a difference. We need double-digit weight loss to really change the complications when it comes to those that's driven by obesity. But when we think about the bypass, more than 90% had more than 15% weight loss. No patient on the best medical treatment arm achieved a BMI below 25, where more than half of patients with a bypass achieved a BMI below 25. Now that's another important thing you as an audience will understand. If you are a cardiologist, diabetologist, also from a nephrology point of view, when you are looking at your targets, very few, if any of your targets have to do with percentage changes. What you have is hard targets. We're talking about a hemoglobin A1C below 7, or we're talking about a total cholesterol, below a certain level, be it 2 or 2.6 millimoles per liter. So we're talking about hard targets. We've never been able to do that with obesity, partly because we don't know what the target should be, and partly because we've never had treatments that could actually get people to those targets. But now the world is changing, and we may actually start thinking whether or not we should also test real targets such as a BMI above or below 30 or a BMI below 25. Looking at the glycemic control, again, you can see just how impressive the best medical treatment is. And yes, surgery did outperform best medicine over here, but certainly the best medicine is doing a good job. When we look at the ADA targets, in this case of a hemoglobin A1C below 6.5, you could see that we achieved that in 25% of the patients with best medicine and 60% in the patients with a combination. So surgery is still superior when it comes to glycemia on its own. That is less clear when it comes to hypertension, because what we were able to show is that there was no difference in systolic blood pressure, but the bypass were better when it comes to diastolic blood pressure. So medicine is not quite as good as surgery, but certainly it's coming close. The place where medicine is failing at the moment is when it comes to quality of life. Because even if you have a body mass index of 35, the most important question you can ask your patient when they come to clinic next time is not whether or not you eat breakfast or not. The most important question is, how do you tie your shoelaces? How do you do your activities of daily living? Because that is really what drives quality of life. Now, this is a little bit of a downside when you work with Brazilians, because everybody is really very happy in Brazil, so it's not very good to look at the mental components. But when you actually look at the physical components, that is where we see the additional weight loss making a big difference. And we're seeing it in all the clinical trials as well. And you'll see a lot of obesity trials now coming out looking at SF36 scores, reporting that there may be a change in the mental health components, but it's really the physical health components that's driving quality of life. That's important because the narrative at the moment has been that what you do when you go to Weight Watchers or another slimming club is that they are going to make you thin and they're going to make you happy. And those two things we can't achieve. But what we can achieve is we can make patients healthier and more functional. And especially the functionality can help them also engage in exercise therapy. That could also help them in the long term. What was the price that we paid from an adverse event point of view? And you'll appreciate that bariatric surgery has been going for the last 50 years. And if you had a gastric bypass 50 years ago, you would have lost exactly the same amount of weight that you will lose when you have a gastric bypass today. So we have not changed the efficacy of the treatment, but we have dramatically improved the safety of the treatment. So now the risk of dying if you've got a gastric bypass is about 1 in 1,000. That's the same risk of dying from a cholecystectomy, or the same risk of dying if you have a laparoscopic hysterectomy. So these surgeries are now incredibly safe and very effective. And actually, we didn't find much difference when we looked at the adverse event rate. There were different adverse events in the two arms, but not a significant number when it comes to severe complications. So let me now switch tack and say, that is what we should do. We should do modern medicine, be that nutritional therapies, exercise therapies, pharmacotherapy, surgical therapies. Modern medicine is ultimately what drove down the mortality rate of patients in the last 20, 30 years. So if people say we shouldn't be medicalizing obesity, it's like, fine, but tell me one other disease that we decided not to medicalize and that has helped us. What we do in medicine is we medicalize things, we diagnose it, we treat it, and then we do the best that we can. So what should we not do? The first rule in medicine is do no harm. And what we have seen played out on our television screens, this is the US called The Biggest Loser, and there was different iterations of that all over the world. But effectively what people did is they took people with a disease of obesity, they dressed them up in funny clothes, and then they ridiculed them, shouted at them, made them run around, and that what they did was not an obesity treatment. In fact, that was a weight loss treatment. And I think we need to, again, differentiate these two concepts. Weight loss treatments are not the same as obesity treatment. So let me show you the response of the gut to the brain when you have a weight loss treatment. So you'll remember what they did is they took 30 weeks, made people run around, made them lose substantial amounts of weight. And then when the same patients were investigated 6 years later, we now understand the science of what has happened. So first of all, yes, you can make people lose a large amount of weight. But look what it is the response of weight loss 6 years later is weight regain. That is not because the patients are not motivated or the patients aren't intelligent. That is just normal physiology. Because if you look on the middle slide, what you've done is you've reduced the resting metabolic rate. And that should happen when people have a significant, substantial amount of weight loss. But look what happens when the weight regain has started. You have not recovered the resting metabolic rate. So really what you have done is you have harmed the patient. If you look at the so-called metabolic adaptation, what has happened over there. And again, you see this every time you come to clinic. People with body mass index of 35 coming to you saying, but doctor, I really don't eat much. And you go, yeah, sure you don't, And that just shows our own prejudices. It is true that patients eat more than they think they eat, but this also shows they eat much less than we think they eat. Okay? And that is important when it comes to understanding the triggers. So if you take a patient who has the disease of obesity, you make them lose weight. What you would have done is you would have created an energy gap. So you would have changed how the gut talks to the brain because you've reduced PYY, you've reduced GLP-1, you've increased ghrelin. Okay? But not only did you do that, you've also reduced energy expenditure. So you've changed the sympathetic nervous system, you've changed leptin. So you've really helped the patient from the pan into the fire. That is if a patient does not respond to an exercise or nutritional therapy. So those are different things. So if you give patients an exercise and nutritional therapy that works for the patient, you do not have this compensation, because what happens is the patient is not under pressure. The patient, there's about 20% of patients who respond to nutritional and exercise therapies, and it's easy for them to maintain. But those 80% that don't respond need to be escalated to something else. So what is the evidence base that is now building? And this is really the message of hope that is coming. So this is the step 1 study with semaglutide. Patients randomized 2-1, 1,961 patients had general lifestyle advice, 500 calorie deficit, exercise 3 times a week, placebo or semaglutide. And you can see the placebo arm lost about 2% of weight, while the semaglutide arm lost about 16% of weight. But that's not the story. The story is if you look at the categorical weight loss. So what you see over here, a third of patients have lost 20% of their weight. Okay? But you will also see here, 8% of patients did not lose weight. And that's so interesting working in clinic, is that, I've seen thousands of people, and I can tell you, I have zero ability to predict who is going to respond and who is not going to respond. It is not the smart people who listen to me that respond, or the people that are not intelligent, that don't listen, that don't respond. This is really biology. So we don't have the predictors pre-intervention that can tell me who's going to end up with 20% weight loss. But this is just a biological treatment for a biological disease. So that was great hope. Now let's go to the next level. So this is tirzepatide. So now what we've done is combined a GIP and GLP-1. Remember when I said with what gastric bypass really do is they have this concert of the hormones really working together. And that is now sort of the next level where we are combining gut hormone responses. So tirzepatide for diabetes, you've seen the data. You've also probably seen the data now for obesity. This is the SURMOUNT study. So now, on average, we get 22% weight loss in those patients. And you can see those curves are not actually completely flat even still. We really need to see the weight loss, over 2 years. But look at the categorical weight loss now. 20% weight loss in 2/3 of patients. 25% weight loss in almost 40% of patients. 30% weight loss in 23% of patients. And the fascinating thing is when you look after patients with these medications, because my clinic, I see patients after bariatric surgery, and I see them now, after medications, and I cannot tell them apart anymore. You cannot tell them apart when it comes to the symptomology that the patients tell you, because patients say, this is so easy. I just do not feel hungry. I feel full when I eat. I'm not thinking about food all the time. I eat smaller portions, but the amazing thing is I really enjoy the food that I'm eating. Right? I eat the food I like. I eat the same food I've always eaten. Right? Now, I just feel normal. And yet they're losing 25-30% of their weight. Now, let's look at these curves that tell us, this is the placebo arm, and you can see here are patients who are responded, to the lifestyle treatment. So these are real responders, people losing 35% of their weight with a lifestyle treatment with the placebo. But when you actually look at the weight loss, what you will also see when we look at the tirzepatide arm, yes, most patients have lost weight. Some people lose half of their body weight with this treatment, but you can also see there's patients who've gained weight while they are on this treatment. Again, the same story applies. You cannot tell which way where patients are going to end up, and it certainly isn't the patients that are trying hard who is actually having a better response. Why is that? Because ultimately, these drugs are not weight loss drugs. These drugs are obesity drugs. What they do is they change the symptoms of the disease. And that's illustrated over here. So the fasting satiety levels, this is both semaglutide and tirzepatide, it increases satiety, and in the fasting state, it reduces hunger. And therefore, it is easy for the patients. But be very, very careful, because it only does this in the negative energy balance phase. Once the patients start hitting the plateau, if they've lost 20 or 25% of their weight loss, they go from 100 kilograms to 80 kilograms. Once they hit 80 kilograms, their hunger becomes normal and their fullness becomes normal. And at that point, the patient says, the drug's not working anymore because, you know, my weight, I'm not losing any more weight, and I'm hungry again and I'm eating more. That's exactly what you would expect from any other treatment that you have, be it, you know, a statin or an ACE inhibitor. If you give an ACE inhibitor, people's blood pressure doesn't go to 0/0, right? It stabilizes because you've controlled the disease, and that is what happens, you know, with this. So that allows us to challenge ourselves a little bit and to think, you know, how can we approach this disease? And I think our previous approach has been focused on energy in and energy out. And I'm going to challenge you with at least another model to consider. So this is my house. And my house temperature is perfectly controlled at 20 degrees Celsius. Right? But you can say that my house temperature is driven by the boiler system that I have, or the very good, you know, double glazing in my house. But, you know, even if my children leave the window open and I lose a lot of energy, my house, the temperature stays at 20 Celsius, because all that happens is the boiler just works a little bit harder. Because the temperature in my house is not controlled by the boiler or the windows. It's not energy in, energy out that controls the temperature. What controls the temperature is the thermostat that sits in my kitchen. And I decide if I want to make my house 22 degrees Celsius or I want to make my house 18 degrees Celsius. So if you think about obesity not as energy in, energy out, but you think of it as a problem with the thermostat, then your approach changes. Because then you will actually think of obesity as a neurological disease. A disease, I'm highlighting the hypothalamus, the area postrema, the nucleus tractus solitarius. So if that is where most of the obesities that we are dealing with, maybe not all, but maybe about 70–80% of what you and I will deal with, you know, is situated in this area. And therefore, this becomes the target of our treatment. So whether or not you use a nutritional therapy, exercise therapy, a pharmacotherapy, or a surgical therapy, you will know that your therapy is working when the patients come back and say, this is amazing because I just feel more full and I feel less hungry. Because ultimately it comes through the common pathway in the arcuate nucleus and the hypothalamus that actually changes the thermostat of the brain that controls the body fat set point. And then the patient have a reduction in appetitive behavior, meaning they're not driven to food, they're not thinking about food all the time. So how do we put this together in a treatment strategy? So we need more self-directed lifestyle changes. We need more public health messaging that allows people to understand, you know, the value of good nutrition and the value of exercise, not as a method to make them lose weight, but as a method to actually improve health. But if that is not enough, then we need professionally directed lifestyle changes. And, you know, our dietitians, our exercise therapists can play a very important role in that. But I can tell within 3 months if it works. If it doesn't work, then the point is not to force people to go around the circle again and again and again. What you then do is you escalate, you know, to pharmacotherapy. And this revolution that's just happening is going to change the way we think about these treatments. It's a little bit the way, you know, I remember, you know, I trained as a lipidologist at the Hammersmith, you know, in 2000, you know, we gave people sand to drink. We gave them Questran, and we had dietitians talking to them, you know, about eating fewer eggs. And then we had statins. And the first thing is we asked the dietitian not to come to clinic anymore. And then we were just able to actually treat patients with modern medicine that change the way, that change the disease profile. But even with pharmacotherapy, there's going to be a substantial number of non-responders. So the question is being asked a lot now. So with these drugs, you know, give you 25, 30% weight loss, there's no point in surgery anymore, is there? Well, in fact, we're treating so few people with obesity that if we're going to start penetrating the disease, we're going to uncover 20% of non-responders, and they have to be treated in another way. And certainly, I think we're going to need more obesity surgery. But even with obesity surgery, there are responders and non-responders, as I've shown you. And about 1 in every 3 patients after surgery in my clinic now are under combination of surgery and pharmacotherapy. So combination therapies. And that's what we do with cardiovascular disease. That's what we do with diabetes. That's what we do, you know, in nephrology. It's not a strange concept. You know, if you give somebody a renal transplant, you don't suddenly stop all the medication. You know, you actually use the combination of surgery and pharmacotherapy to the best of those patients. The problem that we have is that we cannot predict. We can't predict the risk of obesity, and we can't predict which patients with obesity are ultimately going to become very sick until they are sick, and we can't predict which patients are going to respond. And that's what IMI Sophia is trying to achieve, is to try and find the risk, the predictors of risk and predictors of response. So let me conclude and suggest that obesity is a complex and chronic set of diseases. It's characterized by excess adipose tissue that causes a deterioration in health. So the focus is never to make people lose weight, but to improve their health. There's multiple and diverse diseases that result in excess adipose tissue, and we don't have a unifying diagnostic criteria. BMI is really not very good, but it's the best we have, and we need to try and find something better. But this is also an important message. Not all forms of obesity require treatment, but treatment should always aim to result in health gain. So please allow me to thank the team at home that's doing all the hard work, our multidisciplinary clinical team and our multidisciplinary scientists, our international collaborators, and I'm delighted to take some questions. Thank you very much.